Okay, so hi guys. Let me just see if you can hear me. Audio and video all correct. uh, yes. So everybody on? Yes. Yes. So we shall we start, guys? Yes. Okay. Yes, Anuj, we are all set. Perfect. Right. Okay. So good, Abdul, Shweta. Let's start this. So this is so how did you find the test? How did you think the test was? Your feedbacks of the test? So pehle to happy Sunday morning to everybody. Afternoon to everybody. Yes. So yes. So how was the test? Was it good? Was it not good? Was it okay? So basically, the test was no. Yeah. Yes. So basically, the test was just given to explain you the simple questions that can be asked in the exam. The test was not very tough. It was a simple 20 question test, 21 question test, to just highlight that these are the set of questions that can come. Okay, so basically that is the most important thing that all of you should know. So with that, let's quickly start the question so that your Sunday is not wasted upon. So we will quickly try to finish the discussion. And yes, I will be posting tentative questions for the INI CET also before 1 day before the exam, as you always know. So let's see that jinx questions also. So with that, let's start. Okay, so question number one, this question was on the pattern of the repeatedly asked questions in the INI CET. So this was a 60-year-old male presents to the AIMS OPD, and they had given that the crab level was positive and electrophoresis पे M protein is 3.5 gram per deciliter से ज्यादा है, and this is the immunofixation. So the purpose of this question is for you to understand immunofixation, guys. So this, the first band that is here, this is just a ladder to show you the normal pattern of electrophoresis, which I had already explained in the technique video if you attended, or in the Instagram also. That's a very easy way to remember it like this. So the first band is albumin, and then it is alpha 1, alpha 2 beta, and then the gamma globulin, which comes as a hump. Okay, so yes, the first band here which is there is albumin, and then it is alpha 1, alpha 2 beta, and then there is gamma bands. So this is the control ladder which is there, which is always there. Okay, so this is control to show you that we have a control band which is there. Apart from that, look at this. So different immuno antibodies are added. So we have IgG, IgA, and IgM which are put here. So what you see is that in the IgG there is a polyclonal band, there's a diffuse band. So whenever there is a diffuse band in the IgG, that means it's a polyclonal band. Whereas in IgM, you see there is a very diffuse, very pinpoint band. So this is what is called as monoclonal band. This is a monoclonal band. Okay, so what do you see here is that this patient has a IgG polyclonal antibodies which are also increased, but the monoclonal antibody which is increased is IgM. Okay, now if you look at the kappa here, again in kappa there is a particular fixed band which is there. So this is the kappa spike which is there, you can see that. And in the lambda there is a diffuse band again, there is a diffuse band again. So what is the monoclonal proteins in this? That is the question here. So yes, this is a multiple myeloma, but the monoclonal protein here is IgM kappa. Do you understand that? So this is a monoclonal protein with IgM kappa. So if somebody asks you what are the polyclonal proteins here, they can change the question and ask you. So IgG and lambda are polyclonal here. Okay, so they're normally present here. Okay, so there'll be some amount of kappa also there. Okay, so it will not be only lambda, there'll be kappa also which is there. So if it is polyclonal, kappa and lambda both will be present. Okay, so if somebody asks you what is polyclonal here, it is IgG plus there is kappa and lambda. Lambda is thoda sa more than kappa because the ratio of kappa lambda varies from 0.065 to 1.65. So it varies. Okay, so that is why one can be more, but for monoclonal spike, it has to be definitive band, which you can see here. So definitely this is a case of IgA, IgM kappa. That is what you have to know in the immunofixation. Okay. Once you're very clear with this, we all know the criteria for MGUS, smoldering, and multiple myeloma. The point to be noted here is MGUS is monoclonal gammopathy of uncertain significance. This is the most common monoclonal gammopathy, and there is a study which is going in Iceland, okay, which is called as iStop multiple myeloma, and this they are screening all the elderly patients for multiple myeloma, and this is to identify how many percentage of elderly have MGUS in them. Why? Because MGUS is very difficult to identify. So patient does not have any symptoms. So first, there is no symptoms. Okay, no symptoms. Now, if you do the bone marrow, even the plasma cells are less than 10%. So if you do bone marrow, the plasma cells are less than 10%. And if you see the M spike here, it is less than 3 gram per deciliter. So M spike is less than 3 gram per deciliter. So M spike is there, but less than 3 grams. So recently I got a case yesterday. The M spike of the elderly female, 65-year-old female, was only 1 gram per deciliter. The bone marrow was done to see plasma cells. Plasma cells were only 4.5%, that is 4%, and there was no endowment damage. So this female had basically MGUS. Okay, so but the plasma cell should be clonal. That is very important. So it should be only a one clone, either kappa or lambda. That's very, very important here. Okay. Now coming to the smoldering myeloma. So this MGUS usually progresses to the smoldering myeloma. So this is like a MGUS is a precursor stage, and it slowly progresses to smoldering myeloma and multiple myeloma. So whenever we talk about hi Anand. So whenever we talk about smoldering myeloma, you have to remember that in this what happens now is that again there is no symptoms. So koi symptom nahi hota hai, so no symptoms at all. Again, what happens here is I'll again tell you a case which I got recently. So this was an again elderly female who presented with an M spike. M spike was more than 3 gram per deciliter. So once the bone marrow was done, bone marrow, always remember the word clonal. They should be clonal plasma cells, which are important. Clonal plasma cells were 20%. Okay, so they were 20% kappa clonal plasma cells in the bone marrow. M protein was there. Okay, so obviously everybody thought that this is a myeloma, but there were no crab, no slim. Okay, so we will just talk about crab and slim after that. There was no clamp or no swim. So this was something like asymptomatic myeloma. So remember in your brain that whenever you're looking at asymptomatic myeloma, this is basically a smoldering myeloma. Okay, no crab, no slim, only M spike is there, and this M spike and bone marrow shows you clonal plasma cells more than 10%. Okay, but it should not be more than 60%. You know why? Because slim criteria abhi hum padhenge will have, if the plasma cell number, clonal plasma cell number crosses 60%, it is multiple myeloma. Remember that point always. Now, when we talk about multiple myeloma, everybody has to be very clear on this point. Bone lytic lesions, either that is there or slim is there. What is slim? More than 60% plasma cells on the bone marrow examination, light chains, okay, involved to uninvolved are more than 100, and on MRI there is more than 5 millimeter lytic lesion. Okay, so if any one of them are there, that is significantly that means that this is a case of uh, definitely a monoclonal gammopathy, that is myeloma. Apart from that, you have to remember clonal cells, again, if you do bone marrow, more than 10%, and M proteins is present. Okay, M protein is present, but it is not required for the diagnosis. Why? Because we can have non-secretory multiple myelomas also, जो कि सिर्फ light chain बना रहे हैं, so उसमें M spike नहीं आती है. Okay, जरूरी नहीं है आएगी. So that is important. So anytime a patient, elderly patient comes to you, I've told you this story so many times. This is a real story that elderly female comes to you. This was a real case of my, which I have already told you in a lot of my videos also. So elderly male presents to you with more than 60% plasma cells. उसमें कोई M spike नहीं थी, कोई crab feature नहीं था, only more than 60% plasma cells, clonal plasma cells were there. So this is a case of multiple myeloma. You don't require anything else. More than 60% plasma cells आ गए, okay, clonal plasma cells are you can straight away say it as a multiple myeloma. Now, here again, I want to tell you the criteria of plasma cell leukemia is changed, and it can be asked to your exam. So more than 5% circulatory plasma cells agar kabhi bhi hain, so that is called as plasma cell leukemia. Please remember that more than 5% circulatory plasma cells is plasma cell leukemia. Okay, so that is your myeloma, which everybody should be remembering. Apart from that, here is a technique that they can ask you, because they've asked you last time, very high chances they'll ask you this time also. This is electrophoresis principle. So they can show you this image and they can ask you what is this equipment. So this is your electrophoresis. And what do you do in electrophoresis? You put a liquid support media, and in this you can put serum or you can put urine. Okay. And after that you put the charge on both the sides. Okay. And you look for the movement of the proteins on the basis of the size and charge. So whenever you are studying the movement of proteins on the basis of size and charge, this is serum protein electrophoresis. So whenever you look at this, this is how the band comes, which I've told you earlier also. The first band is always the albumin. Albumin is a negative acute phase reactant, so it decreases with inflammation. Both acute and chronic inflammation, it will decrease. Then we have alpha 1. Now they can ask you which all proteins come in alpha 1 region. Please remember, alpha 1 antitrypsin, HDL, okay, TGB, okay, and alpha 1 lipoproteins. They come in alpha 1 region. If somebody asks you what comes in alpha 2 region, very important, haptoglobin, ceruloplasmin, and alpha 2 macroglobulin. So remember very important points here. So in Wilson's disease, ceruloplasmin levels are decreased. So which band will be decreased in Wilson's disease? Alpha 2. If they ask you in hemolytic anemia, so in hemolytic anemia, haptoglobulins are decreased. So which band will be reduced in hemolytic anemia? Alpha 2. Which band is increased? Which condition is increased in in which condition alpha 2 band is increased? Nephrotic syndrome. So in nephrotic syndrome, there is loss of albumin. So albumin is lost, but alpha 2 macroglobulin increases. So that is why alpha 2 band is increased in nephrotic syndrome. Okay. Now beta mein aata hai transferrin and beta lipoprotein. And then we have immunoglobulin, which usually comes as a polyclonal band, So here is the question that they ask you, what are the support media? So if I told you that it has to be liquid, so what are the supports media? Jisme charge move karta hai, proteins can move. So these, what do? You have a tank with the power supply, you have electrodes on this, you have buffer system, and the support media is very important. We have agar gel, agarose, cellulose acetate, and polyacrylamide. So these are your support media that you should all remember. These are your support media that you all should remember. Okay, so these are your agar gel, agarose, cellulose acetate, and polyacrylamide. So I can see my highlight in yellow, but on the screen I'm seeing highlight in black. Is it like that? Is it like gray? Why is the color changed? I don't know. Some issue, some color changes are there. Okay, in the relay maybe. And then we have to do a stain. Please remember, somebody asks you, quantitation of proteins is done by, again, densitometer. Densitometer is attached with serum protein electrophoresis, and it will quantitate the proteins. Okay, so quantitation is done on serum protein electrophoresis only, right? So that is how we do electrophoresis. Please remember, I'm giving you the question. So if alpha 2 macroglobulin is increased, you have to think of nephrotic syndrome. If it is decreased, always think of hemolytic anemia. Okay. Also in Wilson's disease, also it will be decreased. Now, who will tell me this? So beta gamma bridging, we have already discussed this on my Insta recently. So this is very typically seen in cirrhosis. Now, let's look at this case. In the peripheral smear, you see rouleau formation. So remember, whenever we have rouleau formation in the peripheral smear, you should always think of increased proteins, especially myelomas. Okay. Now, once you see this, you do a serum protein electrophoresis immediately. As soon as you did serum protein electrophoresis, what did you saw? So you saw this is a normal person and this is the patient. In the patient, you are seeing a M band. Okay, you are seeing a spike in the M region. So that is very typical M band. Remember, they can give you M band like this also. So you should know how to see it. So this is a polyclonal band, which is normal. And this is your M spike, which I have already explained you, which is typically seen in myeloma patients. Okay. Apart from that, let's look at this case. Let's see how many of you can answer this case. So this is a 25-year-old female with a triad of basal ganglia syndrome, KF ring, which is deposition of the pigment in the copper in the descent membrane of the cornea, and hepatic cirrhosis and hepatic cirrhosis. So if you want to see the band, in which protein the band, in which band will you see, in which region you will see the band. So I hope everybody knows ceruloplasmin comes in alpha 2. So you'll see band in the alpha 2 region. Apart from that, just an overview. There is a macronodular cirrhosis in liver. Very good, Ocean Miles. You're right about it. So remember, how do you diagnose? Because these are stat questions that they ask you. So gold standard is always hepatic copper values, which should be more than 200 microgram per gram of dry weight. So yes, very good, Anuj. So urine also shows you increased copper excretion, which is more than 100 microgram per 24 hours. Serum ceruloplasmins are usually less than 20 milligram per deciliter. Remember, Vinod, I think the colors are disappearing in the relay. Something is happening. The yellow colors are disappearing. The colors are changing. We can't change color in pathology. Some problem in the relay. Can you just check it? So there's definitely some issue with the screen relaying. Everything that I've given yellow is somehow becoming gray. I don't know what is happening. So yes, okay. So ceruloplasmin levels are usually less than 20 milligram per deciliter. And if it is less than 5 milligram per deciliter, it is very characteristic of Wilson's. Apart from that, please remember the serum copper levels are usually low, and very important point, and that's the question that they always ask you, that usually these patients have Coombs negative hemolytic anemia. So this is one point that everybody has to remember. This is Coombs negative hemolytic anemia, which is seen in Wilson's disease. Okay. Now know the basics, which are very simple. So remember, in electrophoresis, you separate on the basis of size and charge. And immunofixation, basically, I put antibodies to separate out proteins. Okay. So that's the basic difference. Quantification is usually done by densitometer on the serum protein electrophoresis. Okay. So that is one thing that everybody has to be very clear. Now let's look at the spot diagnosis. Who will answer this question? So the image on the screen, let me see how many of you can answer this quickly. So quick, tell me what is the answer to this. So what do you see here? Yes. So very good. So this is nothing but this is a band which is seen in G, and the band is just seen in kappa. So this is IgG kappa. Okay. So that's immunofixation of IgG kappa. Let's look at the next image here. Spot diagnosis. Again, this is IgG lambda. Okay. Let's look at one more. Again, this is your control band. So this is your albumin and the other protein. So here you see a band, no band in the heavy chain, but only band in the light chain. So this is light chain only myeloma. This is light chain only myeloma. So is everybody clear? So this is lambda only myeloma. So please remember, इसीलिए it is not important. It's very important to see both the light chains as well as heavy chains, because it can be light chain only myeloma. Okay. Now let's come to the next. Please remember, again, the mutations of myeloma is a very important question. So please remember the standard risk always. So trisomies and hyperdiploidy is much more common than the translocations. So hyperdiploidy is considered as, yes, Shweta, right. So you're right about this. So hyperdiploidy is standard risk. And remember, translocation 11, 14, and if anything which is, so either odd number or duplicate of 3 basically is usually considered as a standard risk. That's a clue to remember. So 6, 14, 11, 14 are considered as standard risk. Apart from that, 4, 14, 14, 16, 14, 20, 17 P deletion, that is P53 mutation, and gain of 1Q. Okay, these are considered as high risk. Okay, so all these are high risk mutation. Apart from that, if your LDH levels are more than 2 times, that means the patient is a high risk patient. Apart from that, if any time a patient has plasma cell leukemia, that is more than 5% circulating plasma cells are there, it is considered as a high risk. Okay, and gene expression profiling usually do not do now, but in West they do gene expression profiling for myelomas. Okay, so that is very, very important. That is how we risk stratify myeloma, which is again an important question that they ask you. So please note this. Okay, now this is the gist of all the electrophoresis that you should remember. So in any acute inflammation, please remember that albumin will be decreased. Okay, in chronic inflammation, there will be polyclonal immunoglobulins which will be increased. If there is a spike in the A2 region, always remember it is your nephrotic syndrome. Beta gamma bridging is cirrhosis, and M spike should always be, after M spike, you should always see immunofixation. Okay. Okay, coming to the next question, which of the following stains causes a brown color to the HER2 positive cells? So remember, this is, you all know, it is diaminobenzidine, and this is your membranous positivity, which is seen. Remember, membranous positivity is a very classical positivity of usually HER2 and any 2 plus HER2 has to undergo fish examination. Okay, so that is a very important question that they ask you. Please remember the profiles of CK7 and CK20 because they are very commonly asked. So the simple rule of life: draw a line at the diaphragm. Anything above it is CK7 positive and 20 negative. So that means your lung, breast, okay, and in lung also mesothelioma. Mesotheliomas are also positive for CK56. Okay, CK56. That is what you have to remember. And calretinine. That is a very important marker for mesothelioma. And in ovarian, non-mucinous carcinomas can be CK7 positive. So if it is coming as CK20 positive and 7 negative, remember, go down, it is colon cancer. Okay, so it is colon cancer. What is a definitive one more better IHC which can be used? It's CDX2. Okay, coming to the dual positive one. So dual positive is always, whenever we talk about double positive, both positive is B for B, it is bladder, and mucinous carcinoma of ovary can also be double positive. Apart from that, double negative are 3 organs which do not follow the rule of the body. So they are hepatic, renal, and prostatic. Why? Because hepatocellular and renal cell carcinoma, normally all the carcinoma spread to the lymphatics first, and that is why we do sentinel lymph node mapping, so the first lymph node mapping. But hepatocellular and renal carcinomas usually spread through veins. Okay, so they spread through veins, and prostatic carcinoma also spread through prostatic vertebral venous plexus. So they spread through vertebral venous plexus. So they spread through different routes, which is different from all the carcinomas. So they are double negative also. So liver, kidney, and prostate are double negative. So that is what you have to remember. These are CK7, CK20 profiles. Very important question that they ask you. These are some IHCs which they ask you again and again in the exam. So please recall that. CDX2 is colon, which I told you. TTF1 napsin is lung adenocarcinoma. P40, P63 is squamous cell carcinoma of breast. Please remember, chromogranin, synaptophysin, CD56, in some, they are all neuroendocrine markers. So small cell carcinoma of lung or any neuroendocrine tumor can show you these markers. Okay, remember that point always. Now look at this. This can be given to you a question like this, and they can ask you to identify the profiling of the breast cancer. So remember, ER and PR are always nuclear IHC markers. Okay, so till the time ER, PR is positive, ER is positive, these are luminal type of breast cancers. Whereas if you see membranous positivity coming like this is HER2 positivity. It can be seen in HER2 positive cancer. Please remember, most common type of profiling is luminal A. That's the most common type of breast cancer, and they have low proliferation. Luminal B usually are associated with BRCA2, and they have high proliferation. Okay, then we have triple negative, that is ER, PR, and HER2. All three are negative. So these triple negatives are usually associated with BRCA1 mutation. So these are some points that you have to remember. Please remember, medullary carcinomas of breast are usually, these are the tumors which are triple negative, usually can be associated with BRCA1. Morphologically, they show you a lot of, plasma cytoid cells which infiltrate, okay, and a lot of inflammatory infiltrate also. But, and grossly, they look like fibroadenoma of breast. They are well defined, okay. So this is medullary carcinoma of breast that is there. It looks so aggressive. It is triple negative, but still it has good prognosis. So this is one point that everybody should be very clear with. Okay. Now, what is the uses of FITC? This was another question that was given in the option. Please remember, FITC is basically used for flow cytometry and immunofluorescence. It's a green color immunofluorescence stains. So it can be used in a lot of places, especially whenever the immunofluorescence is given to edit, like in bullous lesions of the skin. So if you can see, look at this bulla, their basal cells are intact. So this is suprabasal bulla. And all of you know suprabasal bulla has fishnet pattern. So because this is a revision session, so I'm going very fast. So I hope you will remember it. as a pointers, okay, for your exam. So fishnet pattern is very typical of pemphigus. Point to notice all the pemphigus can show you fishnet pattern. Now, a bulla between the epidermis and dermis, that is subepidermal bulla. This is seen in bullous pemphigoid, and you see a linear pattern here. You see a linear pattern here. Okay, so that's very, very clear that everybody should be super clear with, right? So coming to the next question, guys. So FITC is also very commonly used in flow cytometry. Always remember. Okay, coming to the next question here, right? So, which is not true about Hirschsprung's disease? So, guys, whenever I'm talking about Hirschsprung's disease, this is another important question that they're asking you again and again. So, you have to be very clear with this. So, what did you mark in the answer? So, Hirschsprung's disease, histological examination of rectal biopsy confirms the diagnosis. That's true. Okay. What did you mark the answer? So to know this, first let's come to the understanding of Hirschsprung's disease. So everybody knows what is Hirschsprung's disease. It is absence of the ganglion cells in the Meissner plexus of the submucosa and Orbach plexus of the muscularis. Okay, usually in the terminal rectum, but can extend proximally. So these ganglion cells are large pink cells with prominent nuclei. So that is how they look like. Okay, so that is what is very classical of these ganglion cells. Okay, so what is the pathophysiology of Hirschsprung's? Please remember there is a mutation. So RET is the gene which basically controls the migration and differentiation of neural crest cells. Okay, so whenever there is a mutation in the RET gene, obviously the differentiation and the migration of neural crest cells will be affected. So this leads to absence of ganglion cells in the nerve plexus. So when there are no ganglion cells, what will happen? There will be overactivity of the intestine with persistent release of acetylcholine. So there's persistent acetylcholine which will be released, which causes overactivity. So what will happen? Continuous contraction of the narrowed colonic segment. And what happened? Because of the contraction, what happens? The proximal part gets dilated. The proximal parts gets dilated. So that is what is seen typically in Hirschsprung's disease. That's a pathophysiology. So how do you document it? So you have to document either the absence of the ganglion cells, okay, or the overactivity of the nerve cells, which is by acetylcholine. So these are the two things for the diagnosis. Simple as that. Okay. So diagnosis is by histopathological examination of the rectal biopsy. Either you document absence of the ganglion cells in the submucosal and the meningeal plexus. So for that, we use an immunohistochemistry stain, that is calretinin. So remember, this calretinin is also used in mesotheliomas of the lung. Okay. So this calretinin is used. This calretinin identifies the ganglion cells. Apart from that, it also identifies the interstitial small nerve fibers. Okay. So it's a very specific stain because it can be put in the formalin fixed specimen, and it's very, very specific. Or you document hypertrophy of the nerve fibers, which is by acetylcholine. So how do you document that? So for that, you have to document it by acetylcholinesterase staining. So look at this. There is no staining for calretinin. So this is an immunohistochemistry stain for calretinin, which has been put here. And what do you see here? You see here that there is no staining coming. Okay, so no staining coming. So these brown ones here are nothing but some mast cells, which are the internal control cells of the calretinin. Okay, so no staining for calretinin is coming. So that means there is absence of the ganglion cells. The second thing, you document hypertrophy of the nerve fiber. How do you document it? By acetylcholinesterase staining. So you can see a lot of brown things here, right? So that is highlighting the nerve fibers. Please remember, the problem with the acetylcholinesterase staining is that you have to do it in frozen sections. So that is the problem. You have to do it in the frozen sections. That is very, very problematic here. Okay, so that is why acetylcholinesterase staining is not very successful. Okay, right. Now, what is the biopsy which usually we do in neonates? So basically, most of the time, whenever you have to do a neonatal biopsy for Hirschsprung's disease, you do a biopsy which is called as suction biopsy. What is this biopsy called as? Suction biopsy. So suction biopsy is done because there's no sedation which is required, and you can easily sample mucosa and submucosa. You can see the ganglion cells and the hypertrophic nerve fiber, and you have to do multiple biopsies. Usually at least 2 has to be done, but 2, 3, 4 level centimeter above the anal verge, if you do multiple biopsies, it definitely gives you the level and it gives you the diagnosis well, right? So that is the biopsy name that you should know, suction biopsy, right? Apart from that, incisional biopsy, so commonly everybody knows that it is usually done after 1 year of age, but before 1 year of age in the neonatal life, for Hirschsprung's we do suction biopsies. Okay. Okay, now let's come to the next important question that they can ask you in exam is crystals. So I had given you this 45-year-old female who presented with crystals. These were brown to yellow, brown spherical body with irregular protrusions like this. So these irregular protrusion crystals are ammonium biurate crystals. And again, I have told you uh, this in my Instagram video also, that these crystals are usually present in alkaline urine. They're not present in the acidic urine. Okay, so they're common in old urine, and it is what is the utility, what is the beauty of this test, that it will solubilize at 60 degree with acetic acid. Okay, so that is one point that everybody has to be very clear with. Okay, so what are the crystals which are seen in acidic urine versus which are the crystals which are seen in alkaline urine? So acidic urine will usually have calcium oxalate, uric acid crystals, and cysteine crystals, whereas alkaline urine will have triple phosphate and ammonium biurate. So one student messaged me, ma'am, I'm not able to differentiate calcium oxalate and triple phosphate crystal. So you'll understand very simple thing, guys. So calcium oxalate is a square crystal. It's an envelope shaped square crystal. Okay, triple phosphate is usually a rectangular crystal. It's a coffin lid crystal. It is a coffin lid crystal. Okay, it's a coffin lid crystal. So that's one basic difference that you have to be clear. So let's look at them. So look at this crystal. It's a perfectly square shaped crystal. Okay, this is an envelope shaped crystal. So these are calcium oxalate crystals seen in acidic urine. Please remember, these envelope shaped crystals are only seen when they're in dihydrate form. If they're in monohydrate form, they will become like dumbbell shaped. Okay, dumbbell shaped. And also, yes, so also guys, you have to remember, whenever we are seeing these monohydrate crystals, they are very commonly seen in ethylene glycol poisoning. Again, I had asked this question, okay, very commonly. So if in ethylene glycol poisoning, which type of crystals are seen in the urine? They are calcium oxalate crystals. And which type of calcium oxalate crystals? Monohydrate crystals. So that's a very important question that they ask you. So you should be very clear on this, okay? Apart from that, look at these crystals. So these are uric acid crystals. Remember this image always. They are uric acid crystals. They usually can be prism shaped or parallelogram, and they're seen in acidic urine. So this was again a question that this was one of my students from the UCMS who did a project, and he took these photographs from the patient. So this is his photo. So I've given him the courtesy. He's Kanu Bansal. He's now in US. So this he was a CLL patient, and he gave the chemotherapy was given to this patient, and then the crystals were seen. And these crystals which are seen here are uric acid crystals. So very, very important. So this is image by Kanu Bansal. So good image, Kanu. Very nice if you're seeing this ever. So yes. So thank you for giving this image to me. Yes, so that is your very typical uric acid crystals seen in tumor lysis syndrome. Please remember, in tumor lysis syndrome, everything increases except calcium. Okay, so there is increased uric acid, there is increase in phosphate, but only calcium is decreased. So that's another question that they ask you. And which crystals are seen in the urine are uric acid crystals. Okay. Now look at these crystals. These are cysteine crystals, again seen in the acidic urine. They're like stop sign. Okay, so they're like stop sign. That is what you have to remember. Now, this is your triple phosphate crystals, which I told you, they are like coffin lid. Okay, so they are like coffin lid. So they are like this. They are struvite stones. So they are magnesium, ammonium, and phosphate. So always remember this. So that is your triple phosphate crystals, which all of you should be very, very clear with. Okay. Okay, guys. Okay. Right. So that is your triple phosphate crystals, which everybody has to be clear. So ammonium biurate crystals, we have already seen. These are like thorny apples, which we have seen, and they are seen in alkaline urine. And usually they are seen in old samples. Whenever the samples are old, then you see these ammonium biurate crystals. Okay. Now, this is another question that they ask you is DNA double-stranded break repair. So this was again a very important concept, guys, about DNA repair, and they ask you this question. I hope everybody was able to do this question correctly. So X, no X, that was not alginate, that was immunohistochemistry. The counter stain was hematoxylate, and it was IHC in which the brown color was not coming. Okay, it was negative IHC. Okay, for caldating. Okay, I hope you're clear about that X, right? Okay. So which is not helpful in the DNA double-stranded break repair. If you're looking at this, so you have to understand basic things, guys. So what are the first things that you should know in DNA damage? So these are the gist charts that you have to remember. What kind of DNA breaks we can see? See, either we can have UV lights which are causing DNA breaks. So whenever UV light or polycyclic hydrocarbons attack DNA, they form adducts. So they form adducts. So these are the first kind of damage that can occur simply by the UV light. This is called adduct forms. Okay. Now, if there is an ionizing radiation or chemotherapeutic drugs, okay, like a directly acting carcinogen or ionizing radiation, they will cause double-stranded breaks. So they will cause double-stranded breaks. Or sometimes what happens is some ionizing radiation or chemotherapy or oxygen radicals, they cause single-stranded breaks also. And the last, even in many times in the replication process, we can have mismatch repairs which can sometimes occur. Okay, so it's normally C should bind to G. Suppose T comes there, so this is a base mismatch which again causes a problem. So what will happen? Pairing will not occur here. That's a base mismatch that needs to be rectified. So these are the DNA damages that we can have in our life. Okay, either adducts ban gaye hain, या double stranded breaks हो गए हैं, या single stranded break हो गया है, या base mismatch हो गया है. Is everybody clear with that? Okay. Now, repair कैसे होता है? So repair is also very easy to remember. See, if there is, let's say, a base mismatch, एक base mismatch हुआ है बस, then mismatch repair mechanism will get activated, and in this MSH2, MSH6, MLH1 and PMS2 will go and cause the repair. Simple as that. So if there is a base mismatch, there's no problem. It will be solved by mismatch repair gene. So this is a phenomenon of base mismatch which occurs here. Okay. Now, suppose there is adduct formation. Suppose adducts ban gaye the. Okay, adduct ban gaye the. या क्रॉस लिंक्स हो गए थे, like in UV rays, then it will be repaired by nucleotide excision repair. Then it will be done by nucleotide excision repair. So nucleotide excision repair will be done whenever we have DNA adducts. So DNA adducts will cause nucleotide excision repair. Now, once that's done, let's come to the third. If there is a single stranded DNA breaks, this will undergo base excision repair, which is usually by PARP1 and PARP2. So PARP1 and PARP2 are basically for single stranded breaks. Okay, so whenever we have single stranded breaks, that is for PARP1 and PARP2. Now, coming to the last one, if there is a double stranded break, now this has to be very clear. Okay, so double stranded breaks jab ho gaye, so we have healing by two mechanisms. One is called as homologous recombination and the second is called as non-homologous end joining. So homologous recombination mein kya hota hai? It always requires the sister template. So there is a break, so it will start making the copy from the sister template. So it will start making a copy from the sister template. So this homologous recombination is always from the sister template. Okay, so this usually involve which all gene complexes? So ATM identifies it, then it will recruit BRCA2 and FAND, which will call RAD51, and it will start doing repair. So the genes which are involved in this homologous recombination is basically with the help of a sister chromatid, and we have ATM, BRCA2, FAND genes, and RAD51. That is for homologous DNA repair. Now, what is non-homologous DNA repair? So now there is a double-stranded DNA break. So it doesn't wait for the homologous copy. It doesn't have an homologous copy. So here a special group of molecules come and help them. These are called as Q70 or Q80. Okay. So they start synthesizing the DNA there itself. They will start joining without any sister template. So without sister template, they will start repairing it. Okay. So this is by Q70 and Q80. Okay. So this also has Artemis gene and XRCC4. So that is non-homologous. So if you look at that, if somebody asks you what are the genes which are involved in double-stranded breaks, so can I say we have ATM, we have BRCA2, we have FANC, we have RAD51, we have Q70. So these are all the genes which are involved in double-stranded breaks, which everybody should be very clear. Okay. So let's look at that now. Let's come back to the question here. So question was, which of the following is not helpful in the double-stranded DNA breaks? So ATM hota hai. Okay, so BRCA1 and BRCA2 both helps. Okay, so BRCA2 likha, but 2 is more helpful than 1, but both BRCA1 and 2 can help. Okay, BRCA helps. So this is KN70. KN70 is also called as Q70. So Q70 or KN70 are there. So it's, if you know the repair mechanisms, you already know that mismatch repair is a different kind of repair mechanism. It is not useful in double-stranded DNA breaks. It is not useful in double-stranded DNA breaks. Okay, so mismatch repair is whenever there is a mismatch in the nucleotides. That's very important. So that is why it is very important to identify whenever we have a base mismatch. In these situations, we'll have mismatch repair mechanisms that will get activated. Okay, is everybody clear with that? So that's a DNA repair mechanism which should be clear. So please remember, if somebody asks you non-homologous end joining pathways defective in SCID, okay, severe combined immunodeficiency में नहीं हो पाता है. Okay, so SCID cannot heal by non-homologous end joining pathway. That's defective in SCID. Okay, so that's another question that is asked to you in exams. Okay, so is everybody clear with this? So that these are the kind of DNA repairs which everybody should be very clear. Okay. So xeroderma pigmentosa is a disease of which repair mechanism? It is a nucleotide excision repair. So let me see how many of you have understood this. Let me ask you a question here. So this is a 28-year-old female who regularly sunbaths without protection. She has resulted in extensive damage to the DNA in her skin. Thymine dimers were formed and the cells will be carcinogenic without repair. Which kind of repair will fix this abnormality? So who's going to tell me that? Quick. So good, guys. So this is a nucleotide excision repair. Okay, so this mechanism is nucleotide excision repair. Okay, please remember that point, everybody. So that's nucleotide excision repair mechanism will do that. Okay, everybody clear? So I hope everybody knows that non-homologous, so homologous DNA repair, non-homologous end joining will help in double-stranded DNA breaks. Mismatch repair will occur whenever there is a base mismatch. Okay, everybody clear? So the answer to this question is B. It is a nucleotide excision repair which will help this patient. Okay, guys, so you should be very clear with the DNA repair mechanisms at this point. Okay, the next was the urine examination. I hope, guys, you have attended my lecture of instruments where we discussed urine examination, a lot of questions on urine examination which can be asked, and your ESR and PCV. Please revise that because that can always be asked. These are basic techniques which they ask you in exam. So this was a very basic question that was given to you. So 25-year-old male shows tingling sensation in the feet. Father also went. Both the urine test shows various Vibgyor color. Which test is shown here? So obviously this is sugar test which you can see, and it is done by Benedict's test. Okay, so this is by Benedict's test. That has to be very clear. So that's by Benedict test. Okay, so please remember, you have to be very clear as an undergraduate knowing what is the principle of Benedict test. So it just reduces copper sulfate to copper oxide by the reducing sugars, and this copper oxide forms the orange precipitate. Remember, it's a semi-quantitative test. That's a very important thing. So you can just give semi-quantitatively that, okay, Vibgyor, okay, Vib, G-Y-O-R, okay, Vibgyor, and start with 0.5, 0.5, 1, 1.5, and 2. That's how you remember it. It's a semi-quantitative test. So remember, this is the color that is coming here. So this is Vibgyor, which all of you should be very clear. Okay. So this is your Rothra test, which you have to see. The Rothra test is basically to detect the ketone bodies, okay, in the urine, and everybody should be clear. Ketone bodies kaun si pakarta hai? Acetone and acetoacetic acids, and you put sodium nitroprusside in that, and you get this ring here. So that is how how ketone bodies are picked up, and you do not. So remember, this only picks up acetone and acetoacetic acid. Okay, so these are very important here. Apart from that, you have to know this test, guys, a Eldrick test, which everybody should be clear. So if you talk about a Eldrick test, please remember what is an Eldrick reagent. So this is para-dimethylaminobenzylaldehyde, and it is usually put in the acidic solution, that is sulfuric acid. It can be done in blood, it can be done in urine. Okay, दोनों का अपना purpose है. If it is done in the blood, this is to detect tryptophan. If it is done in urine, it is for urobilinogen. Okay, this is for urobilinogen. So Ehrlich tests जो हम बोलते हैं, so if it is done in blood, that is for your tryptophan. So it can be seen in, it gives you a blue violet color, and it can be seen in liver disease, carcinoids, and psychoactive substances, tryptamines and ergo, like LSD, if they are present. That's for that it is used. Okay. Whereas for urobilinogen, when we are putting, as soon as you put urobilinogen, normal urine with the Ehrlich reagent, a pink color will come. This pink color means normal urobilinogen. If it is very dark pink, that means it's increased urobilinogen, and this means there is a excess urobilinogen which is coming in the urine, which can occur either in hemolytic anemia or liver diseases. But if there is no urobilinogen which is coming in the urine, that is absent, that means there is an obstructive jaundice. Okay. So normal is 0.1 to 1.8. So these are basic tests that can be asked. So you should be knowing this. Okay. Now, what is this biuret test? Biuret test is done in serum. It's done in blood. It is for proteins basically. And what do you put it? Again, you put cuprous, copper sulfate. So this copper sulfate bond forms a bond with the peptide bond of the proteins, and it gives you that purple color. So this purple color is considered positive. So copper sulfate normally is blue color dye or substance, whatever you say. So normally you've seen copper sulfate for the for doing the sugar test. Yes. So this is usually a blue color dye. When it changes into purple, that means the proteins are present in the blood. So that is how to do it. So to identify proteins in the blood, we do this biuret test. Okay, right. Okay, perfect, guys. So that is about this. Okay, now let's look at this question. So this is a 45-year-old male presents with refractory DLBCL and card therapy दी गई उसको. Then he starts developing fever, hypotension, tachycardia, tachypnea, decreased platelet count. Lab studies may increased serum interleukin 6, interferon gamma, CRP, and ferritin is also increased. What is the diagnosis? So guys, with this CAR-T therapy is another tentative question that can be asked to you in exam. So whenever CAR-T cells are nothing but they are modified T cells. So they are modified T cells in which we put a receptor for whichever tumor cells we want to target. Okay. So what happens is this, let's say it's a CD19 CAR-T cell. So it will identify the tumor cells, that is CD19 positive tumor cells. It will catch them. So once they engage, the tumor cells with CD19 positive and the receptor engage, these T cells will start releasing cytokines, and it will kill this tumor cell. It will kill this tumor cell. Okay? It will kill this tumor cell. So once this tumor cell is killed, second, it releases cytokines. So whenever there's an excess stimulation of the CAR-T cells, they always have a problem that they release excessive cytokines. So this is what is called as cytokine release syndrome. That's a major drawback of CAR-T therapy. Remember that always. Okay? So if you look at this, what is a CAR-T therapy? So they can give you the image like this, that what is the procedure which is showing here. So you're doing leukapheresis, you're taking out, cells. Okay, after that, you're selecting those cells, whichever you want to take. So your leukapheresis, you have taken all the WBCs. Out of that, you're just selecting the T cells. And then you modify these T cells with the help of, virus, okay, and vector, and you put the receptor in these T cells, and then you expand these T cells. Once these T cells are expanded, you put this back to the person. So that's how the CAR-T cells are prepared. So once the CAR-T cells are prepared, we know that any CAR-T cell has a receptor for the tumor. It will catch the tumor cell and it will kill the tumor. So the treatment to the cancer is only by your immune cells. Only your immune cells can kill the cancers. Okay, so that is how CAR-T cells attack. Any cancer cell or any virus can be targeted by CAR-T therapy. This is the recent mode of therapy which has been invented now. So this is CAR-T therapy, and it came out with a big role. So we started with the first generation CAR-T cells, which was not very successful. Then we said कि क्या problem है T cells अच्छे से काम क्यों नहीं कर रहे हैं, why are these T cells not working? So they realized that every T cell required two signals for getting activated. Okay, signal one is TCR receptor. So when T cell receptor binds to its antigen, that is signal one. Signal two is CD28. When it binds to the MHC complex, it checks it, and then the second signal is CD28 binds with the co-stimulatory molecule. Okay, so that whenever it binds with the co-stimulatory molecule, then only the T cells get activated. So then they made the second generation CAR-T cells with CD28 co-stimulatory. So CD28 co-stimulatory molecule was added. So this is your so this one first was just your TCR signaling domain. This is just a signaling domain. Okay, that is signal 1. Signal 2 is CD28 when it binds with your B8 molecules of the antigen presenting cell. So that is signal 2. So dono chahiye the. So both were put, and then they said, let's see their results. So results were good, but they were not very good. So they gave one more co-stimulatory domain, that is 41BB. So this 48BB was also added as excessive co-stimulator for the T cells, so that more T cells get activated. So for currently we have third generation CAR T cells. Now they are planning to put up fourth generation, that is armored CAR T cells. What are these armored CAR T cells? So they can even release cytokines, flexi cytokines, depending on which cancer cell, which tumor, which virus to be killed, they can release more cytokines also. So problem of all these CAR T cells is excessive release of the cytokines. So once they are you're activating them, they are going to release lots and lots of cytokines. Okay. So which all cytokines they will release? So look at this. So they can release interleukin 6, which can cause fever, inflammation. They can release tumor necrosis factor alpha, which can cause fever, vascular permeability is increased. They can reduce interleukin 1, which can cause fever, tissue damage. They can release interferon gamma that can activate macrophages and more inflammation. They can even release interleukin 2, 8, and 10. So a lot of cytokines are released, which causes vascular leakage, hypotension, and organ damage. So all that is done by CAR T cells, which everybody should be very clear. Okay, so CAR T cells is another question that they can ask you. These are the two current CAR T cells which are there in India. Okay, so one is ImmunoAct, the second is ImmuneEL. So ImmuneEL is with 1BB, that is 41BB. So this is the third generation CAR T cells. Okay, so this is called as vermicabtagene. So this is 41BB. So this is ImmuneEL, and then we have ImmuneAid, which is next CAR. Okay, so that is what you have to remember. This is captagene autocell. So that is very, very important. So these are the two current CAR T cells which are there in India for BALL. Okay, so BALL against CD19. So ImmunoAct and ImmuneEL, right? Okay. Now, please remember, there's a checkpoint therapy also, which everybody knows. We have just now told that normally the CD28 molecules bind with the co-stimulatory molecules of the antigen presenting cells. Okay, so this is CD28, which binds with the co-stimulator molecules, that is B7. And if you look at that, there are two molecules which have a control over T cells. One is called PD1, which is one is called PD1, which is there on the T cell. Apart from that, we have CTLA4. So CTLA4 is a silencing molecule of the T cell. So it is a low affinity molecule, and it is a silencing molecule of the T cells. Okay, so there are two molecules which are present on the T cell. So one is PD1, and second is CTLA4, which can cause silencing of the T cell. So recently they found that the cancer cells basically start expressing PDL1. Cancer cells start expressing PDL1. So with the help of PDL1 on the cancer cells, they go and stimulate PD receptors on the T cells, which causes programmed death of the T cells. So T cells get suppressed. Okay, so that is how the cancer cells were killing our own immune cells. The second is CTLA4. So CTLA4 was causing T cell silencing. So they came up with a checkpoint therapy that, okay, let's make up drugs against these. So they made drugs against these so that T cells cannot be killed. So they came up with anti-PD1 therapy, which is called as pembrolizumab, okay, very popularly called as Keytruda. And the second is anti-CTLA4 antibodies, which is ipilimumab. So that is another drug that came up. So very commonly used for melanomas. Okay, so that is what came up as a checkpoint therapy. Please remember, the Nobel Prize of 2018 went to Dr. Allison and Dr. Takasu Honjo for this. What is the Nobel Prize for this time? Do you know that? And it's going to be question, definitely. It's microRNA. So definitely there was one question in the microRNA also, because that is definitely going to be a tentative question this time. Okay. So now next was one question which basically covers techniques in hematology. So which of the following cannot be confirmed on flow cytometry? So the answer is APL. So for APL, you have to do either FISH or you have to go for PCR. Rest, all of them, the diagnosis of choice is flow cytometry. For hereditary spherocytosis, we have EMA binding test. That is the diagnosis of choice, EMA binding test. For PNH, we know we have a flow cytometry by FLAIR. which is fluorescent, okay, which is fluorescent aerolysin. Then we have chronic granulomatous disease, in which we do dihydrorhodamine test. Dihydrorhodamine test. And then we have Glanzmann thrombocythemia, which all of you know that Glanzmann thrombocythemia is again diagnosed by flow cytometry using CD41 and CD61. Okay, so that is very, very important that everybody has to remember that all these can be diagnosed by flow, but APL, for confirmation of the diagnosis, we require fission PCR. We can always suspect it on flow cytometry, but to confirm, we require fission PCR. And on flow, this is considered as, always remember, HLA-DR negative, CD34 negative leukemia. Why so? Because the arrest is not at the level of the blast. The arrest is at the level of promyelocyte. So the translocation is 1517, which arrests the cell at the level of promyelocyte. So it crosses the blast stage. Okay, so that is why they are CD34 negative and HLA-DR negative. Okay. Now look at this. Okay, so this is how we have a simple flow plots that they ask you an exam. Okay, so that they ask you an exam. So if you put a plot of CD45 with the side scatter, and you are seeing some cells which are coming in the dim CD45 area here. So these are blast. These CD45 bright cells which have low side scatter because they're below, so they have low side scatter, and they are on the positive side here, this side. So they are 45 bright and side scatter is low. They are lymphocytes, normal lymphocyte. These pink cells, okay, so they have little higher side scatter and 45 positive, they are monocytes. And excessive granularity and 45 positive, these are your granulocytes. Okay, so these are your blast gate. This is where the blasts are there, that is CD45 dim area. Okay, so that is what you have to remember. That's a normal flow plot which everybody should be very clear with. So this is EMA binding test. Okay, so we basically tag the RBCs with the EMA dye. Okay, so this dye, using by maleimide dye. Okay, maleimide dye. So this basically directly binds to band 3. So in hereditary spheros, band 3 will further bind to ankyrin. Okay, so band ankyrin, and then they'll be bonding by spectrin and 4.2, all this bonding. So if there is a defect in any of the vertical bonding, any of the vertical bond is broken, it can be picked up by using 5-maleimide. Okay, so that is what it detects, vertical bond breakage. So if ankyrin is the most common defect, if ankyrin is not there, it will cause spherocytosis, band will be broken and the fluorescence will decrease. So what we do is we check the fluorescence, we compare, we always run a control sample and we then run a patient sample. If the fluorescence is reduced, that means the bond is broken. That means there is some breakage in the bond. That is what we do in EMA binding test. Next is this test, which I've already told you. Remember, whenever they give you a history of pancytopenia, okay, so the patient has pancytopenia, plus the patient is also presenting with hemolysis. So remember, the name is PNH. Okay, so this means there is pancytopenia. Okay, there is thrombosis and there is hemolysis. So whenever instead of PNH, you write PTH. So you will always remember it: pancytopenia, thrombosis, and hemolysis. So if all these three are there, this is very characteristic of PNH. So how do you pick them up? Either you use 55, 59, which now we are not using. Now we use FLAIR. And you see the population, how much population is in the negative quadrant. That is, it's negative for 55 and 59. So even if your 1% population is negative for 55 and 59, that is a diagnostic of PNH. That's diagnostic of PNH. Why do you need to identify them? Because one, they can coexist with aplastic anemia. Second, they can progress into aplastic anemia. Third, they can even be progressing into myeloid malignancy. They can progress into myeloid malignancy. So that's why it's very important to pick up these patients. Okay, Wells score is a score for deep venous thrombosis. Okay, it's a scoring for deep venous thrombosis. Okay, let's look at this question, guys. So which of the following is not true about PNH? So this is a PNH graph just to show you that they can give you this graph with 55, 59 and FLAIR.
So this is fluorescent aerolysine. Always look at the negative quadrant. So if you look at the negative quadrant, no cell are there. This is the control, that is normal person. Look at this person here, again 55, 59 and flare. Look at the population here. So there is a big clone, 85% of the cells are in negative. So this is PNH patient, okay? So always remember, you have to always look at this quadrant, okay? Negative quadrant, that is what you have to look for. Okay, bacha log. So question is, which is not true about PNH? Please remember, it presents commonly in childhood. Wrong. It is a disease of adults usually. There is absence of 55, 59 and flare, and it is always a acquired disorder. So all the others are correct. So this is a disease of adults, guys. It does not present in children. And that's another question that they can ask you. Okay. Apart from that, remember what are the antibodies which we use in flow platelets? GP1B. Okay, 1B is 42B. 1B is 42B. Now, if somebody is saying 2B, it is 41, and 3A, it is 61. That is why I told you in Glanzmann thrombocythemia, there is absence of GP2B3A. There is absence of CD41 and 61. So absence of 41 and 61 are very classically seen in Glanzmann thrombocythemia. So in Glanzmann thrombocythemia, there is absence of 41 and 61. Okay, bacha log? Everybody clear with this? Yes? Okay. So anybody who can identify what is this plot? What is this test which is shown here? Anybody who can tell me this quickly? Anybody who can answer this question? What is this test? Quick, guys. Guess. Anybody? Yes. So this is platelet aggregometry. Okay, that's how they give you the graph. See, if there is no aggregation with ADP, adrenaline, collagen, no aggregation with anybody, but some aggregation with ristocetin is still there. This is Glanzmann thrombocythemia. Their aggregation means whenever we look at the aggregation, so normally we see when once the platelets are there in the solution, this solution is turbid. But once the clot is formed, the solution becomes clear. So optical density falls. So that means the clot is forming, okay? So when the clot is forming with the ADP also, adrenaline also, collagen also, so these blue lines are the controls and red ones are the patients. So can you see these red ones are the patients? So there is aggregation occurring with ADP, adrenaline and collagen, but there is no aggregation. That is, the optical density is not decreasing with ristocetin. So if there is no aggregation with ristocetin, which you can see, this is a very classical case. This is a very, very classical case of either Barnold-Solier syndrome or it can be von Willebrand deficiency. Okay, so it can be either, it's an addition defect. It can either be Barnold-Solier syndrome or it can be von Willebrand deficiency, which everybody should be super clear with. So that's platelet aggregometry graph that can be given to you. Okay. And this is your platelet flow cytometry. I told you always look at the negative quadrant here for 41 and 61 also. So if there is negative 41, 61, that means there is absence of 41 and 61. That means this is a case of Glanzmann thrombocythemia. Okay, so can you see 42B is nicely present. That is GP1B is nicely present. But 41 and 61 is not there. 41 and 61 is not there. So that's very classically seen in this platelet flow cytometry. Okay. So now next was this question. Okay, again, it's a repeatedly asked question. So what, this is match the following. So which of the following is autosomal dominant, autosomal recessive, X-linked? So the rule of life that you should always remember that anything that affect eyes and brain is usually mitochondrial. So Leber hereditary optical neuropathy is definitely mitochondrial. So 4 ka to B hai. So choose only the options where 4 are B. Okay, so we are left with only these 3. Now, if you all of you know that Duchenne's muscular dystrophy is always X-linked recessive. So this also we know that this is usually an X-linked recessive. So 2 has to be A. So now we are left with only 2 options, that is either A or D. Now we have to look at cystic fibrosis. Cystic fibrosis is a metabolic disease. So it has to be a autosomal recessive. So 3 has to be C. And last one, autosomal dominant. So myotonia dystrophica is autosomal dominant in inheritance. Okay, so majority of the muscle disorders and bone disorders are autosomal dominant. So to remember what are the X-linked recessive. You should never ever forget this. Any blindness, red green color blindness. Okay, or a patient. There are 2 hematological disorders. hemophilia A and B, and G6PD deficiency are X-linked recessive. Apart from that, you have to remember Duchenne's and Becker muscular dystrophy are also X-linked recessive. Now look at X-linked dominant ones. We have vitamin D resistant rickets. Fragile X is more X-linked dominant, but it can be X-linked recessive also. Alcott syndrome, again, most commonly X-linked dominant, but it can be recessive also. Rett syndromes and incontinenta pigmentae. So these are your X-linked dominant disorders that you have to remember. Autosomal dominant, there are two hematological disorders, von Willebrand and hereditary spherocytosis. Do not forget it. Majority of the muscle and CNS disorders are your autosomal dominant. Exception of the rule is Friedreich ataxia. Friedreich ataxia, okay, which is autosomal recessive. Then all the polyps of the intestine majority are autosomal dominant, except Muthi polyps, which are autosomal recessive. And acute intermittent porphyria and hereditary hypercholesterolemia are two disorders, metabolic disorders, which are autosomal dominant. Okay, so hereditary hypercholesterolemia and acute intermittent porphyria are autosomal dominant metabolic disorders. In autosomal recessive, all the metabolic conditions are autosomal recessive, okay, except acute intermittent porphyria and hypercholesterolemia, which is autosomal dominant. And in hematology rule of two, sickle cell and thalassemia are autosomal recessive disorders. So this is one of the common questions that is asked. So everybody should be very clear in knowing and remembering this. So this was another question. This was match the repeats, guys. So all of you should remember whenever we're talking about repeats, trinucleotides. So the point why I gave this question was to make you understand that now we have trinucleotide and hexanucleotide repeats. Okay, so we can have hexanucleotide repeats or we can have trinucleotide repeats. Okay, so hexa came up recently, in which we have GGGCC repeats which are there. And this is very commonly seen in amyotrophic lateral sclerosis and frontal-lobar dementia. Okay, so these are the two conditions where these came up very popularly, okay, in hexanucleotide repeats. In trinucleotide also, we have a coding region and non-coding region repeats. So if I'm writing a coding region, coding means it's the repeat is always the same. It is CAG. So here the most important disease is Huntington's disease, because Hunter keeps everybody in the cage. Hunter keeps everybody in the cage. But other like spinocerebellar ataxia is also a coding region disease. So apart from Huntington, we have spinocerebellar ataxia here. Okay, spinocerebellar ataxia, which is in cage. Now in non-coding, you have to remember CGG. So this is your Fragile X. This is the second most common cause of mental retardation after Downs. He cannot speak G properly, so it's CGG. That's Fragile X, which is the second most common cause of mental retardation, and it is CGG. Okay, then we have jaw. So nowadays we don't eat fried food. So if we say fried jaw, so this is Friedreich ataxia. Okay, and we have CTG. Okay, so this is myotonic dystrophy. Myotonic dystrophy. So myotonic dystrophy is normally autosomal dominant, but it also shows you trinucleotide repeat inheritance, and which kind of repeats? CTG repeats in the non-coding sequences. So that is the answer for you. So A is CAG, now you know spinocerebellar ataxia. CTG is myotonic dystrophy. Trinucleotide is myotrophic lateral sclerosis, and CGG is Fragile X syndrome. So that's your trinucleotide repeats, which can be asked to you in your exam. So I hope everybody is clear with this. Yes. Okay. Now coming to some molecular techniques that was given to you in exams this time in your aim. So this was one thing that they can ask you definitely this time. So this was basically Jeffrey Chamberlain and workers developed a special PCR where they amplified different dystrophin gene loci. Okay, so this is the chromosome. So he amplified different chromosome gene loci. Okay, from muscular dystrophin using single reaction setup, using different primers. So different primers were put up in a single tube and multiple gene loci were amplified. So this was also used in detecting SARS-CoV virus diagnosis. So what is this technique? This is what is called multiplex PCR. So when you use a lot of primers in a single reaction setup to amplify or to sequence different gene locus, that is called as multiplex PCR. So what are the other techniques also that you remember? So whenever we are doing a single tube reaction with multiple primers, it's multiplex PCR. Now, what is the Sanger sequencing, digital drop PCR, and gap PCR? Let's look at that. So whenever we have to detect deletions, okay, so whenever we have to detect deletions, we detect them with gap PCR. So alpha thalassemia is usually picked up by gap PCR. Okay, so alpha thalassemias are usually picked up by gap PCR. Okay. Now, what is this Sanger sequencing? Remember, Sanger sequencing is the gold standard for the DNA diagnosis. It is based upon chain termination method. What do you use here? Dideoxynucleotides. So you use dideoxynucleotides here. That means they lack the 3' hydroxyl group. And obviously, what is the how much it can amplify? It can give you long pairs. Okay, so sequencing of the DNA can be done up to 1,000 base pairs. So that's the beauty of Sanger sequencing. It's gold standard till now because it can give you the DNA fragments up to 1,000 base pairs. Okay, so that is how the result comes up. Because what you do is when you use ddPCR, so when you use dideoxy nucleotides, what happens is the reaction stops there. So when your reaction stops there, you get different lengths of the DNAs. You can get different lengths of the DNA. So on that length itself, you can plot this plot. So this is how it comes out. So that is the graph of Sanger sequencing. That is how the Sanger sequencing graph comes like. Now, if somebody asks you what is the diagnosis of choice for diabetes type 2, so diabetes type 2, you do not know the disease causing mutation. So whenever we do not know the disease causing mutation, in that case we can either do genome wide association studies. Okay, so either we do genome wide association studies, or we can also do comparative genome hybridization. But diabetes type 2, we take a cohort of diabetic patients to study for the polymorphism which is present in any one of them to identify the diagnosis. So whenever the disease causing mutation is not known and we want to identify the gene, so we take the cohort of the patient and we try to find out the diagnosis. That is done by a technique called as GWAS, that is genome wide association studies. Okay. Now, whenever we have cancer cells which are contaminated, lot of contaminated, earlier days we used to do pyrosequencing in this. Okay, earlier days we used to do pyrosequencing in this, but nowadays the diagnosis of choice is next generation sequencing. So in next generation sequencing, we use adapter molecules. Okay, so I've explained this to you in one of the video earlier also, which I discussed in my channel. Okay, so what do you use? This adapter molecule. So they catch the DNA fragments attached to the complementary sequences and they amplify. So that's a very robust method which can be done, and it is now slowly going to replace in future. It is slowly going to replace Sanger also. So that's next generation sequencing coming in a big way. So whenever we have cancer cells contaminated with the stroma, we have to do next generation sequencing. So how do you do monitoring of CML? So whenever you have to, somebody asks you, how do you do monitoring of CML? So monitoring of the CML has to be done by not only looking at the transcript. So most common transcript that is seen in CML is P210. You have to see the transcript and you have to quantitate it at the same time. So looking and quantitation at the same time, whenever you have to do, for that you have to do RQ-PCR. So RQ-PCR is a real-time PCR. What do you do is you amplify along with seeing the transcript. Okay? So that is the method of monitoring of CML. Now, chain termination with dioxynucleotides, you know, this is what is called as Sanger sequencing. Okay? Another common technique that they ask you is digital droplet PCR. So what is this digital droplet PCR? So in digital droplet PCR, what happens is there's a machine which is called as droplet generator. It generates a lot of droplets. And in every droplet, the PCR reaction is going on. So it's a very robust technique because it gives you very high sensitivity, precision, and reproducibility. So this usually is done whenever we have some rare mutations or whenever we have copy number variations. Then we do digital droplet PCR. So it's a very powerful technique. So even if there is a very rare mutation, very small mutation, very small copy number variation, it can be picked up by digital droplet PCR. So that's how it looks like. You have a lot of droplets in which every droplet is carrying out a reaction. This is a graph in which, you know, you are not only amplifying, you are also assessing it with every cycle. You are assessing how much product is amplified. So this is what is image for RQ-PCR. That is, you identify the transcript and also amplify at same time. So that is RQ-PCR, which everybody should be clear. Okay. So next set of questions. So basically, I try to add new questions so that you know what all questions can be asked. Okay. So look at this question. So what is the correct sequence of staining in the preparation shown below? So this is your papineculose stain, guys. All of you know that these cells which you see here, apart from the cells in the background, so these orangish reddish cells which you're seeing, they are keratinized squamous cells. So this is a case of well-differentiated squamous cell carcinoma because you're seeing orangophilic cells here. Apart from that, if you look at these cells in the background here, these bluish cells, okay, all these are normal intermediate squamous cells. So this pink, light pink color cell here, this is superficial squamous cell here, which is polygonal. So both intermediate and superficial squamous cells are polygonal cells. So point is how we are getting so many colors here. So what is the technique that we follow? Okay, so let's look at the technique. So this was the simple question that was asked, which is the stain which you use for cervical smear. Guys, it's a simple papineculose stain. So this is papineculose stain which is used for staining. How do you use it? Basically, you use 5 dyes in 3 solutions. So first dye that you use is hematoxylin. Okay, so first dye that you put is hematoxylin. Either you put Harris hematoxylin or Gills hematoxylin. You put hematoxylin. Okay, so this gives you the nuclear color first. So nuclear color aa gaya blue. Now we put orange green G, orange green 6. So once we put orange green 6, it identifies the mature squamous cells. Okay, so mature squamous cells, if they are there, it will be identified here. Then we put the third stain, which is a mixture of 3 things: eosin Y, light green SF, and Bismarck brown. Okay, so we have eosin Y. So eosin Y basically identifies all the mature squamous cells. All the mature squamous cells will be identified. Okay, that will give a pink color. Then we have light green SF. Basically, it identifies the blue colored cells, so parabasal, columnar cell, intermediate squamous cell. So it will give you the blue color. And Bismarck brown Y does not give the stain, but it is important for the viability of using Y and light green. It is just present for the crispness, for the viability. That is why it is added. So these are the 3 stains which are put in this order. सबसे पहले आप डालते हो, first you put as hematoxylin. First you fix it with 95% ethanol. After that you put hematoxylin to stain the nucleus. Then you put orange 6 to identify if there are any keratinized squamous cells. Then you put eosin azure. Eosin azure basically has 3 things in it. It has eosin. Is eosin matlab pink, azure matlab blue. So it has eosin, which I've already talked about. Okay, eosin Y. And what gives the blue color here? Light green SF. So light green SF gives the blue color. Okay, so that is why it is called eosin azure. Eosin azure. So okay, hematoxylin डालो, orange डालो, then उसके बाद आप eosin azure डालो. So that's how the staining of pap smear is done. So these eosin azure which we have formed, they come with different numbers: 31, 50, 65, which is given by the companies depending upon which ratios these are mixed, in which ratios this eosin Y, light green, and Bismarck brown is mixed. Okay, so that's the staining procedure which we have talked about: hematoxylin, orangey, and eosin. So remember this always. Okay, so HOE, that's the staining things that you have to do. OA, right? And that's your well differentiated squamous cell carcinoma, showing you the orangish reddish keratinized squamous cells. Okay. So there was another question that was asked: which of the following is used in liquid-based cytology? So the image, the graph that was shown you was for liquid-based cytology. So what do you use for liquid-based cytology, guys? So in liquid-based cytology, you're using this brush. Okay, so this is called as broom. Okay, so which we scrape the area, and we cut its head and put it in the fixator. That's how we put a broom, and we put it in the fixator itself. So broom, we put it in, we cut the head and we put it into this so that no material is lost. That is sure path. And if you look at the circles here, this is how it comes. So this is your traditional pap smear which is there. So this is your sure path, okay, which we do. It's 13 millimeter. Thin prep is 20 millimeter. So it's a thicker, bigger circle. So we use SurePath. It's a smaller circle to screen and the quality is very good. Okay. So that's what we have remembered. That's how the bottles come, EA60, EOG6, like that. Okay. So once we have seen what is the adequacy of pap smear is another question that is asked. Okay. So we require in a conventional pap smear, we require 8,000 to 12,000 squamous cells, whereas for liquid based, 5,000 cells are enough and at least 10 endocervical cells are mandatory. So that's the adequacy criteria for the pap smear. These many cells we need. It's a come cells where we cannot give it adequate. Okay, so this is a googly question. I'm sure all of you would have answered this. This is a repeat question from your INI CET. So which is true in sickle cell anemia? Remember sickle cell anemia, I've already told you this so many times that these sickle cells are very dehydrated cells. Okay, so they are dehydrated cells. Then so if you put them in the water solution, they will keep on taking more and more water. So that means they will not burst. So that is why this is called low osmotic fragility. So osmotic fragility is very, very less. Good, Kartika. So osmotic fragility of sickle cell anemia is very, very less. But they because of repeated cyclings or repeated cycles of sickling, non-sickling, sickle, non-sickling, the membranes have become fragile. So they are highly mechanically fragile. So they are mechanically fragile, but the osmotic fragility is low because they are dehydrated and they can take as much water as you give them. Okay, so which organ is marked by arrow A? So this was one thing that many of you have marked it wrong. So what is this? This is a duct, guys. Okay, so it doesn't have a lining. Can you see these are just alveoli lying like this? Okay, like a passage. There's no lining epithelium on it, long lining epithelium on it. So this is your alveolar duct. This is your alveolar duct. So you have to be very clear with the lining when we talk about. Okay, so first, remember when we talk about the bronchus, so bronchus has mucosa and the submucosa. So we have epithelium, lamina propria, muscularis mucosa. We have submucosal gland, and we have cartilage. So this is very important structure of the bronchus. Bronchus has cartilage to keep it patent. Okay, so you even create a Reid's index with it, that in which you count the thickness of, you measure the thickness of submucosal gland divided by the complete thickness, and normally it is less than 0.4. So that is characteristic Reid index which you see in normal bronchus. So if your Reid index becomes more than 0.4, it is very characteristic of chronic bronchitis. So that's your normal bronchus that you see. Okay, if you look at the bronchioles, now bronchioles are the lack of cartilage. So first thing that happens is there's no cartilage, but some mucosal glands are still there. So no cartilage now. So now once you go to terminal bronchioles, the size will become less than 2 millimeter. That's it. The size will become less than 2 millimeter. So if you look at this is the terminal bronchiole. It has the lining epithelium. Now the lining epithelium will slowly become it is columnar only. Okay, it will become columnar. It will slowly start becoming cuboidal, but lining epithelium is there. The size, if you look at the size, it's smaller and the well defined lining. Okay, after terminal bronchiole we lead into acinus. It will lead into acinus. Acinus is made up of three things. The code is RDA. Okay, so R is respiratory bronchiole, alveolar duct, and alveolus. Okay, so what is this respiratory bronchiole? So this respiratory bronchiole, when you look at this, it's lined by the cuboidal epithelium. इसमें lining होती है. So it's lined by the cuboidal epithelium, which you can see here. Okay, this one here. It's lined by the cuboidal epithelium, and it has at least one alveoli which is connected to it. It has one alveoli which is connected to it. Okay, so it has a lining epithelium, and it has one alveoli which you can see nearby. There will be one or two alveoli. So that's respiratory bronchiole. It has alveoli around it. Okay. So that's respiratory bronchiole. Lining becomes flattened. Duct is just a passage with no lining. Can you see there's no lining epithelium? So that is duct. This one, the bunch of grapes, if you see bunch of alveoli, okay, so like this is your alveoli. This is your alveoli. Okay, so this is your alveoli, which you can see. This is your alveolar duct, which you can see. And this is your respiratory bronchiole, which you can see. So that's your terminal, your acinus. Okay, so we have respiratory bronchiole here, we have alveolar duct here, we have alveoli, we have a terminal bronchiole on the top, which we have already seen here. So that's how we differentiate. There should be no confusion in this. So remember, we have bronchus, which has cartilage. Reid index calculate kara aapne. Then we come to below to bronchioles. Bronchioles do not have cartilage, but glands, some mucosal glands are still there. Terminal bronchiole, सबसे छोटा वाला, but it has the lining epithelium well defined. It opens into acinus, that is respiratory bronchiole. One alveoli is usually connected to it. It has a lining epithelium. Then alveolar duct is there, no lining epithelium, only passage of the duct. It is like a duct-like structure with alveoli around, and alveoli, a bunch of grapes of alveoli. Okay, so that's a basic structure which you should understand because they ask you. Also remember that the lung is the epithelium of the bronchus is very unique because it also contains neuroendocrine cells. Okay, so apart from the ciliated columnar epithelium, it also has neuroendocrine cells which are there. Okay, okay. So that's about normal histology. So next question was, which of the following is not a criteria of metabolic syndrome? And this is another question which you should know. So you should know the WHO criteria of the metabolic syndrome. किसको कहते हैं metabolic syndrome? Number one of the first diabetes होना चाहिए. Diabetes could be either diabetes, yeah, insulin impaired insulin glucose tolerance, or impaired fasting glucose, or insulin resistance. Anyway, it should be like diabetes. So one of the following should be there. Diabetes हो जाए, फास्टिंग ग्लूकोज बढ़ा हो, ग्लूकोज टॉलरेंस खराब हो, इंसुलिन रेजिस्टेंस हो जाए. ठीक है, and two of the following, what do you need? So one is diabetes, which we have covered. The second is that what all can happen. So any person who is diabetic will have BP. The BP will be high. Lipids will be dyslipidemia, that is triglycerides will be high. Okay, and triglycerides will be high, the HDLs will be low. Okay, third, the urine में protein आने लग जाएगा, so there will be microalbuminuria. Okay, so this is simply remembered as bad. Okay, so bad things start happen once you become diabetic. Also, once you become diabetic, bad things start happening. So what is B? B say blood pressure, E say albumin, and D say dyslipidemia. Okay, so bad things happen, become problematic, you're in the urine, and diabetes occurs. The next important thing is usually these patients are mental obesity. So either that can be assessed by body mass index, which is more than 30, or waist to hip ratio can be calculated. So that is it. So we don't calculate the hip circumference. We take waist to hip ratio, or we take the BMI. So yes, blood pressure. Okay, so high blood glucose. Okay, this is the main one. Plus, if you have the high blood pressure, okay, and albumin is also coming. So yes, these are bad things are happening. So that's the criteria for metabolic syndrome. So yes, that's perfect. Okay, so waist circumference is more important rather than hip circumference. Okay, good, Kartika. So this was a googly question. All increase in iron deficiency anemia except, so you all know that iron deficiency anemia is a true Vikhari. TIBC is high because there is no iron. To protoporphyrin will be high, and bone marrow will try to increase its erythropoiesis. Okay, because it's not producing as many cells as it should, so it will increase the serum transferrin receptor. Serum transferrin receptor is directly proportional to erythropoiesis. So everything increases is in iron deficiency except transferrin saturation, because there's no iron, there's nobody to bind to transferrin. Yes, so transferrin saturation is decreased. Okay. So this question was again your INI CET 2024 question. I've just modified the question a little bit. This is a patient who has undergone both liver and kidney transplantation, and now he's presenting with nodules on this scalp. What is not true? So if you look at these, can you see these are the macrophages, and in the macrophages these are calcified bodies which are there. So remember, these macrophages are called as von Heinzmann macrophages, and these bodies are called as Michaelis-Guttman bodies. And I've told you this story so many times that what happens is, this is like a macrophage who's not able to kill the bacteria. So what will he do? He will calcify it. If you remember that story, you will be able to answer. If you've heard this story anytime in my videos, also I've told this story so many times. It's a story of a sadhu, okay, who can curse you and change you into a stone. So that is this sadhu, okay, because he cannot kill you, he can change you into the stone. So what this occurs whenever there is a defective macrophage lysosomal digestion of the phagocytosed bacteria. So these Michaelis-Guttman bodies are nothing but they are dystrophic calcification, which usually occurs inside these macrophages. Usually they are intracellular, but yes, they can be present extracellularly also. And they are very beautifully picked up by von Cosa and alizarin red, not by the Masson trichrome. Masson trichrome is basically for your collagen and muscle. So it gives you blue color to the, Guys, you're able to hear me? Everybody, are you able to hear me? Yes or no? Okay, you are. Right. So, yes. So, yes, so that will be picked up by mass, and trichrome picks up collagen and mast cell. It gives you blue color to the collagen and red color to the mast cell. Okay. Perfect, guys. So, if you look at this, that's how the lesions typically appear in the cystoscopy also. The malakoplakia is most commonly seen in bladder, but they can be seen in any other place in patients of immunodeficiency. So this patient had both the transplant, so that is why these patients usually can develop malakoplakia. And again, they can ask you which stain will highlight them. So it's a calcium, so it can be highlighted either by von Posa or alizarin red. So that is how the Michaelis Guttman bodies appear on von Posa stain. Yes, alizarin red is more specific. CD68 is a marker of histiocytes. So von Heinzmann macrophages, if somebody says that which stain will identify von Heinzmann macrophages, then your answer should be CD68. Okay? Okay. Okay. Thank you, Harsh Singh and Kartika. Yes. So next question was acquired mutation in gene coding histone 3.3 is seen in. So guys, the purpose for this question was to just make you understand that bone tumors are equally important. So please revise them if you have not. And to just tell you, small cell carcinoma of the lung, everybody knows, usually has RB gene mutation and LMIC. So yes, so that is out, right? What about the others? Let's look at this bone tumors. So first, you should know which are the tumors which arise from the epiphysis. It's chondroblastoma and giant cell tumor, diaphysis, Ewing's sarcoma, metaphysis, most of the bone forming tumors, osteochondroma, and all of this. So there are 4 bone tumors which everybody should be clear in terms of microscopy. If you're looking like this, lacy osteoid, the term is lacy osteoid. So this has to be osteosarcoma. This has to be osteosarcoma. Can you see, look at this? What is this? Around every cell, you can see the calcification, that blue color calcification around every cell you're seeing. This is called chicken wire calcification. Chicken wire calcification. This is seen in chondroblastoma. Chondroblastoma. If you look at the rosettes here, okay, so if you start seeing the rosettes and just blue cells in sheets, okay, like this, like a small round cell tumor, this is very classical of Ewing's sarcoma. This is very classical of Ewing's sarcoma and peanut. Okay, so you see, you can see the rosettes and you can even have just blue cells in the sheet. That's Ewing's. Okay. Now, most of the cells, if you focus, they have the cytoplasm appears little clear or uh, clearish. Why? Because they have a lot of glycogen in the cytoplasm. So they have a lot of glycogen in their cytoplasm. So they will be stained beautifully with pastane. Yes, very good, Kartika. And this is your C-shaped Chinese like trabeculase. So this is your fibrous dysplasia. This is your fibrous dysplasia. So that is another thing that you have to remember. Okay. So these are common bone tumors. Now let's come to the common mutations in the bone tumor that they ask you. So starting first with the osteosarcoma. So osteosarcoma, the culprit commonly given is chromothripsis, that is chromosome shattering. So this chromosome shattering is a common phenomena which occurs in osteosarcoma. So I hope you know chromothripsis. We have discussed it in the general pathology quiz also in my YouTube channel, right? Also, apart from that, you have studied that RB gene deletions are the most common in this osteosarcoma also. And apart from that, MDM2, which is a controller of P53, is also increased in this. Okay. So these are P53 mutations and MDM2 is increased in osteosarcoma. If you look at the osteochondroma here, we have X1 and X2 mutation, which decreases the heparan sulfate, and Indian hedgehog pathway is decreased. So that's classical of osteochondroma. Ewing's, we all know that it is 1122. That is EWS FLI1. We'll talk more about it. Chondrosarcoma, very important, guys. This is oncometabolism mutation. So I hope everybody knows that IDH1 and IDH2 was discovered first in oligodendroglioma. More than 90% of the oligodendrogliomas had IDH1 and IDH2 mutations, but chondrosarcomas also have that. Now, in giant cell tumor, it's an acquired mutation. So that is why it is very important. And it is in histone 3.3. So that's a very, very important mutation of giant cell tumor that you should remember. Apart from that, aneurysmal bone cyst also have chromosome 17p rearrangements, okay, rearrangements, and usually the gene which is involved is USP6. So USP6 gene is usually involved in aneurysmal bone cysts. Okay. So if you look at the 1122, we all know it's Ewing sarcoma, but remember 2122 or 922 can also be Ewing's, depending upon the what is the partner. So normally we have EWS, that is Ewing sarcoma, FLI1, that is 1122. That's on 11. Now we have 2122 also. In that the partner becomes ERG. Then the partner becomes ERG. So if they're giving you a partner of ERG, that is 2122. If the partner is CHN, that is 922. Normally, 922 translocation is a very classical translocation of CML, that is ABL-BCR, and with 190 transcript. Okay. But you should remember 922 can be Ewing's also, depending upon the partner genes. Okay. Now, apart from that, 1722 translocations are seen in two conditions. So one is DFSP, the second is nodular fasciitis. So these are two conditions where 1722 translocations can be seen. Okay. So dermatofibrosarcoma protuberans and nodular fasciitis both have 1922 mutations. So USP6 can be seen in an aneurysmal bone cyst, but can also be seen in nodular fasciitis. Please remember a very classical history about nodular fasciitis that they give you. It is that it usually occurs after trauma. So they give you a history of trauma, and it usually occurs in the forearm. After trauma, they started developing swelling in the forearm. This is made up of spindle-shaped proliferation, and the mutation showed you USP6. Then your answer will be nodular fasciitis. Okay? So that is one thing which you should be very clear. Sometimes they give you this finger like this, and they show you that there is a lot of giant cells in the finger like this. So this is nothing but this is what is called as tenosynovial giant cell tumors, guys. So this is tenosynovial giant cell tumor, which is very common condition, which is seen in the FNAC. So please remember this condition. So many giant cells when they are seen in the finger like this, okay. So that is tenosynovial giant cell tumor. So they do not write this as a giant cell tumor of the bone. This is tenosynovial giant cell tumor. Ewing's doesn't look like that. Pigmented villonodular synovitis also doesn't look like that. Pigmented villonodular synovitis will show you a lot of villi projections from the joint and a lot of hemosiderin-laden macrophages. So that is why it is pigmented, because there is a lot of hemosiderin-laden macrophages, villi, because it's projecting from the joints. So that is PVNS, pigmented villonodular synovitis, which shows you a lot of hemosiderin-laden macrophages and the proliferations. Okay, now let's come to the next question. Yes. So this is a patient who has rash all over the body and CBC में anemia hai, platelet count is 15,000. Okay, so can you see the platelet count is less than 20,000? Okay, absolute reticulocyte count ideally should be more than 20, should be less than 20,000, but they have given the reticulocyte count is 0.5. So even if they have given you RBC count, you could have calculated absolute reticulocyte count by multiplying the reticulocyte count into the RBC count, but that's not given, so it's okay. So apart from that, they have not even mentioned absolute neutrophil count, which is very important. So if your absolute neutrophil count is less than 500, this is called severe aplastic anemia. If your absolute neutrophil count is less than 200, it is called very severe aplastic anemia. You all know that this patient is having anemia, thrombocytopenia, and the reticulocyte count is also decreased. So this probably can be a case of aplastic anemia. But they have given you a very classical thing here that bone marrow biopsy also shows you fatty streaks and absent megakaryocytes. So fatty streaks and absent megakaryocyte is a very classical feature which you see in aplastic anemia. In PNH, normally in the early phase, the bone marrow is hypercellular. Later on, it progresses to aplastic anemia. But initially, the bone marrow is cellular. Shows you a lot of erythroid hyperplasia because there is hemolysis occurring in the periphery. So bone marrow responds by causing erythroid hyperplasia. MDS will show you dyspoiesis. Okay, so there will be dyspoiesis. It can be in the form of pawn ball megakaryocytes in the bone marrow or in the peripheral smear as Pelger hued cells, binucleate neutrophil. Okay, disseminated tuberculosis will show you granuloma on the biopsy. Aspirate might not show you anything. So this is a typical case of aplastic anemia where the bone marrow you can see normally the age of the patient is 40%, so the cellularity in the bone marrow is always calculated by 100 minus the age. So 100 minus 40, the cellularity should be 60%. Here the cellularity is less than 10%. So definitely it is a aplastic anemia. Okay, so that's how you diagnose the aplastic anemia. So remember, whenever they give you pancytopenia, always remember whether it is a cellular bone marrow or hypocellular bone marrow. If it is a hypocellular bone marrow, you have two differentials. One is aplastic anemia and the second is hypoplastic MDS. So in hypoplastic MDS, they will give you dyserythropoiesis in the megakaryocyte, like pawn ball megakaryocyte. Now, cellular bone marrow, what are the causes? Are number one, MDS. Classical MDS will usually be cellular. Number two, megaloblastic anemia. Megaloblastic anemia is pancytopenia with hypercellular marrow. Okay. Number three, I'm writing it here. Number three, autoimmune causes. Okay, like SLE can cause pancytopenia with cellular marrow. Okay, then the fourth is storage disorders. So like Gotcher. So I've not given you the image of Gotcher, but please remember the Gotcher's is always a tentative question. Okay, so Gotcher's disease. Then Gotcher's Niemann-Pick. Okay, Niemann-Pick disease. Fifth, hypersplenism. Hypersplenism. Hypersplenism is always there. Okay, right? So these are some of the important causes of pancytopenia with hypercellular marrow. Apart from that, malignancies also can do like that, especially many malignancies can cause like that, like hairy cell leukemias can have pancytopenia with dry tap and cellular bone marrows, like that. Okay, so that is what you have to remember. So pancytopenia with cellular and hypocellular marrow should be very clear. Okay. Okay. So salt and pepper chromatin, if you're seeing with dense core granules and in some positivity. So the question for is just to identify which are the neuroendocrine tumors, you know. So carcinoid, neuroblastoma, Merkel cell, all are neuroendocrine. Papillary is not a neuroendocrine tumor. So please remember, this was asked in the INI CET exam also. Neurosecretory bodies are seen in all except. So remember, again, adrenal cortical is not a neuroendocrine tumor. So all the others are. So they can change the question accordingly. So please remember, these are very characteristic dense core granules, which are typical feature of neuroendocrine tumor. So which are the neuroendocrine tumors? You know, the neuroendocrine tumors can either be pheochromocytoma, neuroblastoma, paraganglioma, carcinoid, small cell carcinoma of the lung, medullary carcinoma, and Merkel. So Merkel cell carcinoma is very characteristic because it occurs in the elderly male, usually in the skin, and they have dot-like positivity for CK20. And that's how the question is asked always. Look at that histopathology. They will always have a very typical chromatin as if you have spilled the salt and pepper. Immunohistochemistry, you know that it is NSC, synaptophysin, chromogranin, bombacin, CD56, and recently added in someone. And on electron microscopy, dense core granules are there. Okay. Now, what are these paragangliomas? They can be pheochromocytoma if they're occurring in the intraadrenal, or if they're extraadrenal, they can occur outside the adrenals. So they can be carotid body tumor, glomus tympanicum, globus vagale. All these are basically extraadrenal ones. And remember, paragangliomas show you typical microscopy. This is called Zellballen pattern. That is the nest of tumor cells surrounded by the sustentacular cells. So next question that they can ask you, which of the following is not associated, which of the following gene is not associated with pheochromocytoma? So please remember, guys, that what are the genes which are associated with pheochromocytoma? Always remember, it is associated with MEN2. Number two, it is associated with NF1. That is very important. Please remember, NF1 is a very important question that they ask you again and again and again. NF1 is associated with neurofibroma, pheochromocytoma, and pilocytic astrocytoma in the brain. So that's a question that comes always. So apart from that, pilocytic astrocytoma can extend to the eye. So optic nerve gliomas can be associated with NF1. So that's another question that can be asked. Optic nerve gliomas can be associated with NF1. Then VHLs. So VHLs is another important question. All of you know what are the tumors most commonly associated with VHL. So remember always, most common is hemangioblastoma. It's a vascular tumor because it controls the vascularity, but it's a tumor of the cerebellum. Apart from that, it is a tumor. It causes clear cell renal cell carcinoma. It causes pheochromocytoma, which we have just now seen. Okay. It causes pancreatic serous cyst adenomas. and it causes endolymphatic sac tumor. Okay, so these are the common tumors which are associated with this VHL mutation. So that is one of the important questions. Again, SDH is an oncometabolism, very typically associated with GIST and paragangliomas. And EPAS1 is associated with polycythemia paraganglioma syndrome. So these are common 5 genes which are associated with paragangliomas. So you have to know this very well. Okay, so that is classical. Okay, everybody please remember that. Okay, so remember MEN2, NF1, VHL, SDH, and EPAS1 are associated with pheochromocytoma. So if you remember the recall from 2024 INI CET, this was the question which was changed. Which of the following is associated with GIST? Okay, with GIST except, okay, with GIST except. So you know that. So we have already talked about this always. Okay, so KIT is associated with 80% of the GIST. PDGFRA is associated with 10%, and SDH is very common. Oncometabolism, which is associated with GIST. NF2 is not. Okay, so NF1 basically not associated with GIST, but normally NF2 is not associated. So what are the tumors with NF2? Everybody should know that also. Remember that very easily. How do you remember it? You remember it as schwannoma, ependymoma, and meningioma. So 3 tumors here. Remember, smooth endoplasm, okay, SEM, okay. So that is 3 tumors with NF2, schwannoma, ependymoma, and meningioma. What are the 3 tumors with NF1? You already know this, okay. NF1 is associated, number 1, with pilocytic astrocytoma, pheochromocytoma, and neurofibroma. So these are the tumors that everybody has to be clear, because this is how they ask you the question, okay. So you should be very clear with this, okay. Okay, and this is the last 21st question I gave this because I feel this should be a tentative question this time. This is on microRNA, guys. All of you know that it typically, what does microRNA do? So this microRNA comes out from the nucleus, sits in the car, that is ribosomal induced silencing complex, and it breaks the target mRNA. So when it breaks the target mRNA, it causes RNA cleavage and it breaks out the RNA, or it sits in front of the RNA like a stone, and so no protein synthesis can occur. So either it can cause translation repression or it can cause mRNA cleavage. So that is the 2 things that it can cause. So it causes gene silencing. Good, Kartika. So remember, it causes gene silencing by causing either cleavage or translation repression. So it's post-transcription gene silencing. Yes, it is 22 nucleotides usually in the size, and it contains 6,000 mRNA. That's correct. So this technology is knockout technology. Why? Because it's not affecting the DNA, it's affecting the RNA. So DNA is still there. So once you affect the DNA itself, it is knockout. CRISPR is a knockout technology. Okay. So CRISPR is a knockout technology. So microRNA is a knockdown technology. So microRNA is a knockdown technology because it does not break the RNA. It does not break the DNA. It just breaks the RNA. So it's a knockdown technique. Perfect, Kartika. You've already told the answer. So what are the other points that you have to remember? MicroRNA is 22 nucleotide, and if they ask you about long non-coding RNA, they are more than 200 nucleotides. Please remember, it comes out from the nucleus. So Dicer works on it, breaks it into a single-stranded microRNA, sits in the CAR, that is ribosomal induced silencing complex, which will take it to the target RNA, either break it or sits like a stone to stop the protein synthesis. So this causes gene silencing. So this is what is knockdown technology. Knockout is done by CRISPR. Please remember the full form of CRISPR, which is always asked. So this is clustered, regularly interspaced, short palindromic repeats. Do not confuse this. They can just ask you the short form. And human genome codes about 6,000 miRNA, and synthetic microRNA are siRNA. Please remember what are the common ones, microRNA in disease for now. So we have microRNA 15 and microRNA 16 in CLL. These are common ones because they cause BCL2 activation. Apart from that, microRNA 155 is also seen in many B-cell lymphoma. Yes, very good, honest endeavor. And I'll finish the session with one question here. So let me see how many of you match this correctly. Chocolate for anybody who matches this correctly. Match the epigenome regulatory genes with the cancers. So let me see who matches this quickly. So epigenetics and the cancer is another tentative question that can be asked to you. Anybody? No? Okay, I will start. So DLBCL usually has association with CREB PP and EP300. Okay, so malignant rhabdoid tumor is a specific rhabdoid tumor which has a typical epigenome mutation of SNF5. Renal cell carcinomas are usually associated with PBRM1 mutation. This is an epigenetic modification in them. And follicular lymphomas are usually associated with MLL2. So this is the chart from the Robbins where from which I framed this question. So this is from the neoplasia chapter, table 7.9, which is very important. Remember DNMT3A, this is a very important tentative question. DNMT3A is mutated in acute myeloid leukemia. It can be asked you in exam, please. MLL1 again in any acute leukemia in infants, it is MLL1. MLL2, please remember, it is in follicular lymphoma. CREB BP, I told you just now, DLBCL. Okay, ARID1A, we have talked about this. Clear cell carcinomas, either in ovary or endometrium, will have this. Okay, SNF5, we just talked, malignant rhabdoid tumors, we will have that. Okay, then PBRM1, this is a new mutation seen in the renal cell carcinomas, again, very important. And recent one that they have told that histone H3 variants, okay, histone H3 variant mutations are seen in pediatric gliomas, and depending on the location, the variations are different. Okay, so these are pediatric gliomas which are associated with histone 3 variant. Right? अभी मैंने आपको बताया acquired histone 3.3 mutation is seen in giant cell tumor of the bone. Okay, so that is all you should know. So these are the important and the rare topics that we discussed today for your exam. So yes, guys, so I hope you would have learned something from this session. And yes, please do look forward for my one day before Jinx questions, which I always post before the INI CET. Do see them before you go for your exam. Apart from that, please keep revising well, because revision is the key, and any piece of information which you're getting from anywhere is super important. So revision is the key. Keep revising well. So keep performing, be consistent, be disciplined, and I'm sure I'll be seeing you on the other side of this table very soon. Right, guys? So with that, bye-bye. Hoping to see you on the other side of this table soon. All the very best, guys. Bye-bye.
Thank you, ma'am.